everyone. My name is Cui Cui, come from Orthopedic Department of the First Hospital of China Medical University. In this lesson, we are going to learn the bone and joint injury of upper limbs. In this chapter, we have 10 sections. Section 1 is the fracture of clavicle. Section 2 is the dislocation of acromioclavicular joint. And the third section is dislocation of the shoulder joint. And the fourth is fracture of the proximal humerus. The fifth is fracture of the shaft of the humerus. The sixth is the supracondylar fracture of humerus. The seventh is dislocation of the elbow. The eighth is the subluxation of the radius head. The ninth is fractures of both radius and ulnar. The 10th is fracture of the distal radius. Section 1 is the fracture of the clavicle. The brief anatomy. The clavicle is an S-shaped bone connected the arm and trunk. And it's commonly happening in juvenile and adolescence, and often resulting from a direct blow or a fall on an outstretched arm, and usually in the middle part of the bone, closed fracture. The treatment option for non-displaced fracture, we use a sling for 3 to 6 weeks. And for displaced middle part of the fracture, we do the reduction by manipulation. Use a figure of 8 shape bandage. And the traditional treatment always make the patient feel discomfortable, and its lack of proven benefit. So the indications for open reduction and internal fixation, the first is the patient cannot bear the discomfort of the bandage. The second is dislocation after reduction, poor local appearance. And the third with blood vessels and nerve injury. The fourth is open fracture. The fifth is a non-union of fracture. The sixth is a distal part fracture with ligament broken. And these two pictures shows how we do the surgery. We can use the plates and the screws and the intramedullary nail. Section 2, dislocation of the acromioclavicular joint. And it happened commonly in young people, often in sports. Always in direct force and indirect force, and more common in direct force. The classification, we can classify it into 3 types. Type 1 is the joint sac and ligament injury, not broken. The type 2 is the joint sac and ligament partially broken. The distal end of clavicle subluxation. The X-ray can manifest it. And the type 3, the joint sac and the ligament totally broken. The distal end of clavicle dislocated. And the manifestation, we can use the X-ray examination, contrast with the contralateral part, and the arm tracked by the weight of 4 to 6 kilograms. For the treatment, for type 1, we can use a sling for several days, and for type 2, we can do it as type 1. Also, we can do the reduction by pressing pad and sling. And we also can do the close reduction and fixation and the fluoroscopy. Also, we can do open reduction operation. For type 3, we do the operation. This picture shows the sling and how we do the surgery. We can use the plates and screws, also the K-wire, to do the surgery. Section 3, dislocation of the shoulder joint. The classification, we can classify into the anterior type, posterior type, superior type, and the inferior type. And also the anterior type is the most commonly seen. We can classify the anterior type into supraglenoid, infraglenoid, and the supraclavicle type. And it's often caused by indirect force. The manifestation and diagnosis, we can make the diagnosis according to the history and pain. And the shoulder will show a square shoulder deformity. And here is a very important concept. It is called Dugas sign. When the patient has a dislocation of the shoulder, we ask the patient to put his hand on the shoulder. He cannot contact his elbow to the chest. Then we say that the Dugas sign is positive. And we can use the X-ray examination to rule out fracture. And for treatment, we can do the reduction, use manipulation with local anesthesia, like Hippocrates method and so on. And it's very difficult to do the reduction for patients more than 2 weeks dislocation. And some need the branchialis plexus anesthesia or even general anesthesia. Sometimes open reduction is necessary. And the fixation, we can use a sling for 3 weeks, 1 to 2 weeks longer for those with fracture of great tubercle of humerus bone. And we use a bandage to the chest wall. The third is the rehabilitation. Section 4 is the fracture of the proximal humerus. It is commonly in elderly people, especially those with osteoporosis, mainly in the fall down and by force. The classification, the first type is non-displaced, the second is abduction type, the third is adduction type, the fourth is comminuted fracture. And these 3 pictures shows the non-displaced type, abduction type, and adduction type. And for non-displaced type, we use sling for 3 to 4 weeks. For abduction type, we do the reduction by manipulation, and we can use external fixation like cast and splints. For adduction type, we can do the reduction by manipulation, use external fixation like abduction frame. For the comminuted type, for elderly people and weak people, we can just use a sling and wait. And if the operation is possible, we can do the operation. And 4 to 6 weeks later, then restart the shoulder movement. And we can also use bone traction and plaster cast. This picture shows the fracture and how we do the surgery. We can use plates and screws. Also, we can use artificial joint. Section 5 is the fracture of the shaft of the humerus. It can cause by direct or indirect force, and often with displacement tracked by muscles. And the lower 1/3 part fracture may complicate with the radius nerve injury. The manifestation, there's maybe a deformity and pain, and a disturbance of movement and injury of radius nerve. These 2 pictures shows the different displacement of the bone according to the different muscles tracked. And for treatment, we can do the manipulation and external fixation. We can use the splints 6 to 8 weeks for adults and 4 to 6 weeks for children. And also we can use plaster cast. And the open reduction and the internal fixation, the indications conclude: first is the failure after multiple manipulation, and the second is the insertion of soft tissues. The third is the injury of blood vessels and nerves. The fourth is bone non-union. The fifth is union with deformity. The sixth is multiple limb fractures. This picture shows the fracture and how we do the surgery. Section 6 is the supracondylar fractures of the humerus. The brief information. The supracondylar is the part between the shaft and the condyle, and it is relatively weak. And there's nerves and arteries pass. It is relatively common in children under 10 years old, and it may hurt the epiphyseal plate and block growth, and may have deformity with the elbow joint. The classification conclude the flexion type and the extension type. The first is the extension type. The manifestation, according to the history and pain, the deformity and X-ray. The treatment, we can do the manipulation for those shortly after injury. No obvious edema and distal circulation disorder. We can do the operation for those failed manipulation, open injury, and with nerve and vessels trauma. This picture shows that this kind of fracture can cause the nerve and the vessels injury. The second is the flexion type. Nerve and the vessels injury relatively rare, and for treatment, we can use external fixation for 4 to 6 weeks. And for those with elbow deformity, after bone union, we can do the operation can be formed if the deformity turned permanent. This picture shows this kind of fracture. And section 7 is the dislocation of the elbow. We can do the reduction as early as possible and classify this kind of dislocation into posterior type, lateral type, and anterior type. And the posterior type is the most commonly seen. The manifestation, we can, according to the deformity and the movement disorder, also we can use the X-ray. For treatment, we can do the reduction by manipulation. The sign of success is the movement restore normal, and those dislocation for more than 3 weeks, we can do the operation. The second is fixation, and third is rehabilitation. Section 8 is the subluxation of the radius head. It is relatively common in children under 5 years old. And the manifestation and diagnosis, we can, according to the history and of arm traction, and the child refused to move arm and grab items. And the X-ray shows negative. And for treatment, we can do the manipulation, reduction. Anesthesia is not necessary. Remind the adult family members to avoid arm traction. This picture shows how we do the manipulation for reduction. Section 9 is fractures of both radius and ulnar. The classification, here's two kinds of important concepts. The first is a Montague's fracture. It is the proximal 1/3 fracture of the ulnar with radius head dislocation. The second is Gleasius fracture. It's distal 1/3 fracture of the radius with ulnar head dislocation. And for treatment, we can do the manipulation reduction. The second is the operation and the internal fixation. The indications conclude manipulation failed, open fractures, nerve vessels tendon injury, and the multiple fractures of the same limb, and union with deformity. The third is the rehabilitation. Section 10 is the fracture of distal radius. The brief information. The fractures at less than 3 centimeters part to the distal articular surface of the radius. And the classification, we can classify into extension type, flexion type, and articular surface fracture with dislocation of the wrist. The first is extension type. We also call it Colles fracture. It is a very famous fracture. And the manifestation, we can see the lateral position. We can see a fork deformity. And the X-ray shows the distal part move to radial and dorsal direction, and proximal part to palm direction. For treatment, we can mainly by manipulation reduction. And the second is flexion type. It's Smith fracture. It is contrary to the Colles fracture. And we do the manipulation, and we use the splints and the casts. The third is the articular surface fracture with dislocation of wrist. We call it Barton's fracture. The manifestation is similar with Colles fracture. This picture shows the fork deformity. And this picture shows the structures and the anatomy around the wrist. And this picture shows the X-ray of this kind of fracture. This picture shows the AP position and lateral position of this kind of fracture. And this picture shows how we do the surgery. We use the plates and the screws to do the reduction, internal fixation. That's all. Thank you.